Hello everyone and welcome to MetaFam. So in this video series we will be discussing some clinical cases, and then we will be discussing the disease associated, the pathogenesis, the clinical presentation, diagnostic studies, morphological feature, differential diagnosis, treatment, and some correlations of the pathological, physiological, anatomical, pharmacological correlations. Okay, so the first question is here, and this is a 5-year-old boy and present to the pediatrician. Okay, so 5-year-old and boy present to the pediatrician with yellow eyes, pale skin, and dark urine. Okay, his mother states that he began having upper respiratory symptoms 2 days ago. So there is an infection going on of the upper respiratory tract, most probably upper respiratory tract, and the duration is 2 days ago. She also states that her brother has similar episodes. So it is this disease is somehow passing from generation to generation. Okay, when he gets a cold. Okay, so infection is associated with this disease. Okay, now this CBC is notable for normocytic anemia. So the patient is having anemia, elevated bilirubin levels, and negative fluorescent spot test. So you must remember the thing that this fluorescent spot test is used for the NADPH level. Okay, so if it is negative here, that means there is deficiency of the NADPH. Okay, and the other thing, that is peripheral blood smear reveals hinge bodies and bite cells. So what is hinge bodies? Hinge bodies are the oxidized hemoglobin. Okay, hinge bodies are formed from the oxidized hemoglobin. Okay, oxidized hemoglobin. And also the peripheral cells show bite cells. Okay, bite cells. So the hinge bodies and bite cells are the diagnostic feature for the G6PD deficiency. G6PD deficiency can be our probable diagnosis. Now the pathogenesis of the G6PD deficiency. So this is an X-linked recessive disorder. This X-linked recessive disorder satisfies our condition of, she also states that her brother has similar episodes. Okay, so X-linked recessive disorder is satisfying this statement. Okay, and now there are hundreds of variants of this disease, and at the subcellular level there is an inability to produce enough NADPH, and because of that there is deficiency of this NADPH, and the fluorescent spot test is coming to be negative. Now what is the function of this NADPH? To reduces the glutathione. Okay, the function is to reduce glutathione. So now the glutathione is not reduced, and there, whenever there is oxidative stress, this will cause hemolysis. Okay, now because of this correlation between oxidative stress and hemolysis, there will be periodic hemolysis. Okay, and there will be absence of the chronic baseline hemolysis. So chronic baseline hemolysis will not be there. There will be periodic hemolysis. Now periodic hemolysis can be related with the infection. Okay, so the first thing that the patient will present with this, the patient will present with these symptoms when he or she will be having infections. Okay, the one important thing that you must know is this patient will also present with the symptom when he will be consuming the fava beans. Okay, fava beans can, the question can be asked by this fava beans, that whenever patient consumes the fava beans he will be having these symptoms. Okay, and also any exposure to oxidizing medications, will make the patient to have these symptoms. Now what are the oxidizing medication that can be triggering these symptoms? The first one is the primaquine. Okay, primaquine is an anti-malarial drug, and this is used to kill both hypnocytes and the gametocytes. Okay, so this primaquine is contraindicated in these patients because this is an oxidizing drug. Also the methylene blue, then the sulfur drugs, and the nitrofurantoin, these are some drugs that should be avoided in this G6PD deficiency patient. Okay, so any exposure to infection and ingestion of fava beans and oxidizing agents will trigger this patient symptoms of this patient. Okay, now one more important thing that you should know, that this disease G6PD deficiency is more common in males, and also the geological, also it is more common in African and Mediterranean origin. Okay, so people with this geological presentation will have more chances of having G6PD deficiency. Okay, now this African and Mediterranean region gives us a differential diagnosis, that is sickle cell disease. Okay, sickle cell disease is also more common in these geological parts, and because of this, now what's the difference between SCD and our G6PD deficiency is the SCD will present with the chronic baseline hemolysis. Okay, chronic baseline hemolysis, and also the hinge bodies and the bite cells will be absent in the patient. We can find the HBS levels in sickle cell disease that will be absent in our G6PD deficiency. Okay, and now the clinical presentation. So the patient will present with anemia, hyperbilirubinemia, okay, and hemoglobinuria. We have already talked about the triggers. The morphological features will be hinge bodies and bite cells. And now comes the treatment part. So treatment will be, the first thing we will be doing is the treatment of the infection. Okay, now we will be avoiding the medication that can trigger the symptoms. Also, if the patient is consuming these drugs before he came to us, so we will be stopping these drugs. Okay, also the hydration of the patient during this hemolytic episode is very important. Okay, life expectancy with the G6PD deficiency is normal, so the patient will be having normal life expectancy. So this was all about this video. Okay, and if you have any doubt, please feel free to ask in comment box, or you can DM us your doubt on our Instagram channel. And if you have any doubt other than this video, you can even ask that also. Okay, thank you friends.